Welcome to The Funnel Effect. We are diving deep today into what is probably one of the most persistently complex and challenging problems for interventional cardiologists. We're talking about how to identify and, more importantly, successfully treat calcified nodules, or CNs, within the context of percutaneous coronary intervention, PCI.
Yeah, and this deep dive is built entirely around a really critical state-of-the-art review from a group of, true leaders in the field. The paper is titled Identification and Treatment of Calcified Nodules in Percutaneous Coronary Intervention. And the authors are Ziad A. Ali, James C. Spratt, Aloka V. Finn, Akiko Maihara, and Dusip Shin, published in Euro Intervention.
And our mission today, for you, the learner, is to really unpack the findings in this review. We're going way beyond just, coronary calcification is bad. Ooh. We need to understand the unique structural complexity of these lesions, the high-tech imaging you absolutely need just to see them clearly and critically, why the standard playbook so often fails. We're going to get into a fascinating, and I'll say it, a counterintuitive treatment paradox that is forcing everyone to rethink their entire strategy.
It really is. The authors establish right away that CNs are consistently rated among the most challenging lesion subsets to treat with PCI, period. And the high risk of adverse outcomes comes down to two distinct but related failure modes. First, you have the acute failure. The stent simply won't expand because the nodule is like a rock, stent under expansion. And second, and this is maybe worse, is the late failure. This is where the calcified material physically reprotrudes through the mesh of the stent.
Wow.
So this demands a tailored, highly informed approach that, it has to begin with just identifying the thing properly.
Okay, so let's start right there. Let's define this thing. What morphologically separates a CN from just a random lump of calcium?
Right. So a calcified nodule is a very distinct type of calcified coronary lesion. It's characterized by a protrusion into the vessel lumen with a convex surface. It literally sticks out like a bump or a nodule. And crucially, this protruding nodule is often flanked by or adjacent to these long segments of the artery that have these hard, heavily calcified sheets.
So you have this bump, but it's surrounded by, rigid armor plating. That just sounds like the perfect recipe for trouble when you try to, push a stent in there.
It is, and the paper gives us some interesting clues about where they show up. They're frequently found at what are called coronary hinge points.
Hinge points?
Yeah. These are the sections of the artery that are subjected to the highest degree of movement, flexion, and torsion during the cardiac cycle, the parts that bend the most. They also tend to occur in parts of the artery that historically had a high lipid burden and a propensity for forming a necrotic core.
Ah, okay. So you combine a vulnerable structure, that weak core, with a specific anatomical spot known for constant motion, and you start to see why these things are so unique.
Precisely. The clinical significance of CNs stems directly from that combination. Their complex structure means they have a highly variable response to standard treatment. They demand specialized modification, and as we'll get into, they have a very specific way of making stents fail that's different from, just simple calcification lining the vessel wall.
Okay, so let's unpack what they call this prevalence paradox, because this is where things get really interesting. If CNs are so distinct and cause such specific problems, why does it feel like we've only really been hearing about them as a major focus recently? Where were they 20 years ago?
That is the core of the paradox, and it all depends on how you're looking at the patient population. If you look strictly at studies of patients presenting with acute coronary syndrome, your classic heart attack like the MGH-OCT registry or the Tactics registry, eruptive CNs are actually the least frequent cause of the clot.
Wait. The least frequent?
The least, yes. In those big ACS studies, CNs are only responsible for maybe 4.0% to 7.9% of cases. They are completely dwarfed by the classic mechanisms we all learn about first. Plaque rupture is number one, and plaque erosion is also way more common.
So if you were only looking at what causes the immediate dramatic heart attack, you might just write these off as a rare curiosity.
And that's the logical fallacy the paper points out, because if you look at routine clinical practice, the story completely changes. CNs are far, far more prevalent than that ACS data would suggest.
Because they're not just an acute issue. They're a chronic structural problem that dictates how hard the procedure is going to be.
Exactly. Let's look at the numbers. The Prospect substudy used 3-vessel IVUS to look at plaques that hadn't caused a problem yet. They found CNs in 17% of the arteries they could analyze, and in 30% of the patients.
30% of patients. That's a huge number.
It's massive. And here's the number that every interventionalist needs to have in their head. When you're dealing with patients who need advanced mechanical prep, specifically rotational atherectomy or RA intravascular imaging, shows CNs in up to 50% of those lesions.
50%. So it's a coin flip. The minute you decide you need to use a burr, there's a 50-50 chance you're actually dealing with a CN.
Yes, it just shifts the whole clinical picture. And even in the plaques that did cause the heart attack, about a third of the really calcified ones are actually CNs. This means you have to be actively looking for them anytime you see heavy calcium. You can't just ignore it.
That's a fantastic point. Your reaction to seeing severe calcification shouldn't just be, I need a drill. It should be, I need imaging to see if this is a CN.
Exactly, because the treatment is different, and we have to zoom in on the high-risk groups. Prevalence is higher in patients with diabetes, prior bypass surgery.
But the big one is chronic kidney disease, right?
Crucially, yes. The rates are way higher in patients with CKD, especially those on hemodialysis. Studies show CNs are in about 40% of the culprit lesions in ACS patients who also have CKD. The paper really emphasizes this because it gets at the systemic nature of calcification in these patients. It's the high calcium and phosphate burden that seems to drive the formation of these things.
So it's like CKD doesn't just make plaque worse in general. It specifically accelerates the development of this really nasty, structurally challenging nodular calcium. The moment you see a CKD patient with heavy calcification, your suspicion for a CNS should just go through the roof.
It has to.
Okay, so let's get into the why, the pathobiology. The source breaks CNs down into two fundamental types. Let's talk about the active versus the stable.
Right. We classify them as either eruptive or non-eruptive CNs, and this classification is vital. It dictates everything. Eruptive CNs are the active form. They're associated with ACS, with sudden cardiac death. Histologically, what you see are multiple fragments of dense calcium that are literally penetrating a disrupted fibrous cap. You've got endothelial cell loss and, critically, a thrombus, a clot sitting right on top. They are biologically active.
And then the non-eruptive CNs are the chronic, stable version.
Correct. They're more stable, sometimes just called nodular calcification. They present as stable angina, or they might even be asymptomatic. The key difference is they have an intact fibrous cap. There's no thrombus on top. The lesion is still protruding, but the surface is sealed over.
So if the eruptive one is like an open bleeding wound, and the non-eruptive is a stable healed over bump, is just an evolution of the other.
That's the leading hypothesis. It's thought that a non-eruptive CN might actually be a healed form of a prior eruption. The idea is that an initial eruption causes intraplaque hemorrhage, this internal bleeding. Over time, that resolves through this complex process called osteogenic transformation.
So the body, it basically turns the old blood into new bone-like material?
Essentially, yes. It integrates all those little sharp fragments into a larger mass and heals the cap over the top. The histology supports this. You see fibrin and inflammatory cells mixed in with the calcium spicules, suggesting this cycle of damage and repair.
Which brings us to the most critical mechanism here, mechanical stress. The paper is adamant about this. This is the hinge theory. Can you help us visualize what's actually failing here?
Okay, imagine a brittle, dry sponge sandwiched between two sheets of granite. That's the structure. Eruptive CNs start from these necrotic core calcifications, and the key detail is that these core fragments lack collagen.
And collagen is what gives plaque its strength, its flexibility, so the middle is inherently weak.
Exactly, it's brittle. So these weak fragments are sandwiched between those rigid, collagen-rich calcified sheets on either side. Now you add the hinge motion, the constant flexing, bending, and twisting of the artery as the heart beats. That motion acts like a grinding force on the brittle core, causing it to break down and eventually erupt through the surface.
That makes the location preference, like the mid-RCA, make perfect sense. That's a known high-motion area.
And there's objective evidence for this. The paper found that the development of de novo CNs is associated with a larger change in the artery's angle between systole and diastole. So the lesions that are actively forming are in the spots that are physically bending the most. Mechanical motion isn't just a factor, it's a primary driver.
It's the physical stress that turns a stable rock into an unstable volcano. Which also means if you treat it without accounting for that environment, you're just setting yourself up for failure later on.
Precisely. Once that initial fragmentation happens, it starts this vicious cycle. The sharp calcium fragments damage tiny capillaries inside the plaque, causing more internal bleeding and fibrin deposition. You even see angiogenesis, new, fragile blood vessel growth inside the CNs.
And that just fuels the fire. It keeps the lesion growing and active.
It does. This cycle drives progressive growth and pushes that nodular material out. Eventually, those sharp fragments just tear through the fibrous cap and the endothelial lining, and that's your trigger for the acute event. Platelet aggregation, thrombus, and a full-blown ACS.
So we've established these things are a unique disease of structure and motion. You need the perfect storm, the right kind of brittle calcium and the high motion hinge environment to literally grind it down and push it out.
That's it. It's fundamentally different from a simple plaque rupture.
Okay, so moving from the why to the how do we manage these? The paper is very clear. Angiography alone is often not enough. In fact, it can be misleading. Why?
Angiography can raise suspicion, for sure. You're looking for what's called an angiographic radiolucent mass, or ARM. It's a filling defect in the contrast.
But that could be a lot of things, especially in a heart attack.
Exactly. An ARM is nonspecific. It could just be a regular thrombus. But the real challenge is twofold. First, the absence of an ARM does not rule out a CN. You can have one without seeing it on the angiogram.
And if you do see an ARM, it can actually fool you in a different way.
It can. Angiography often overestimates the stenosis severity when an ARM is present. And while, enhanced technologies like stent boost or clear stent help you see the stent better, they still fundamentally lack the morphological detail. You can't classify the nodule. You can't see the cap.
So this is where intravascular imaging becomes non-negotiable. You have to get a camera inside the artery.
Oh.
Let's compare the tools. IDUS versus OCT.
High-definition IVUS, intravascular ultrasound, gives you good penetration. It sees CNs as these bright, hyperechoic protrusions with acoustic shadowing behind them, a big dark shadow. And importantly, HD IVUS can reliably distinguish between eruptive and non-eruptive CNs. It can see if the fibrous cap is broken or not. Eruptive ones have an irregular surface, often with thrombus. Non-eruptive ones have an intact cap.
And then you have optical coherence tomography, OCT, with its superior resolution. This gives you that almost microscopic picture, right?
It's an incredible picture. On OCT, CNs appear as these signal-poor, heterogeneous areas pushing into the lumen, and the difference is visually striking. Eruptive CNs have this rugged, irregular surface with obvious thrombus on top. You can literally see the cap is gone. Non-eruptive CNs on OCT have a smooth, bright surface, which tells you the cap is intact and sealing it off.
Okay, so the resolution is amazing, but the paper highlights a huge functional limitation with OCT when it comes to deciding how to treat the nodule.
That's the catch. OCT has limited penetration depth. The light just doesn't travel that far through calcium or blood. This means it struggles to characterize the plaque underneath the nodule, at its base.
And why is that underlying part so critical?
Because the deformability of a non-eruptive CN, whether it's going to squish or not, depends on what's at its base. Is it soft, residual lipid that you can compress? Or is it more deep, hard, rigid calcium? OCT can't reliably tell you that, so you know it's a non-eruptive CN, but you still don't know if you need to shave it, shatter it, or just stent it. And right now, that answer often requires a bit of trial and error.
Okay, let's talk about those treatment challenges, because this is where the rubber meets the road. The paper lists a whole bunch of specific failure mechanisms for CNs.
It's not just one problem, it's like 4 or 5 happening at once. First, the immediate risk is stent underexpansion. The non-deformable nodule just won't compress. The stent can't fully open.
And the second point, this is the one that's really unique to CNs, isn't it? The long-term failure.
Absolutely. The second and really problematic mechanism is early CN reprotrusion through the stent struts. The nodular material finds the gaps in the mesh and just extrudes, causing in-stent restenosis. It's the core reason for late failure. Third, because they're at those hinge points, you have a higher stent fracture risk. The constant motion just fatigues the metal.
And what about the surrounding area? It's not just the bump itself that's the problem.
No, and that's a key point. The heavily calcified sheets next to the nodule often create the minimal stent area, the tightest spot. In one analysis, the tightest spot after the procedure was outside the nodule in over 57% of cases.
Wait, really? So you could focus all your energy on debulking the visible bump and completely miss the actual flow-limiting segment right next to it?
Precisely. You have to treat the whole calcified segment. And all of this is layered on top of the fact that these patients often have CKD, which is its own independent predictor of poor outcomes.
So let's define deformability. When we say we want to squish it, what does that look like on imaging?
In the OCT studies, a CN is defined as deformable if there's a visible reduction in its protrusion after you treat it. The goal is symmetric stent expansion. Think of it this way. The nodule has to be compressed enough that the stent can form a nice round lumen. If it's not deformable, the balloon just expands eccentrically around it.
Okay, this brings us to the central finding of the deep dive, the paradox. Let's break this down.
This is where it gets really counterintuitive. If we just look at what happens during the procedure, the subtypes behave exactly as you'd think. Eruptive CNs, they are almost universally deformable.
Because they're made of that fragmented, soft, mushy stuff.
Right. Fragmented calcium mixed with lipid and fibrin. They compress easily. You get great stent expansion. They look fantastic right after the procedure.
And the non-eruptive ones.
Their deformability varies. About 2/3 are deformable, probably because they have some soft lipid at their base that you can squish. But the other third are non-deformable. They're just hard, dense, calcified components. You can't compress them, and they often need advanced modification.
So acutely, the eruptive lesions are the easy ones. They squish, they expand, the operator feels like they got a great result. But the long-term paradox is that these acute wins become chronic failures. Despite looking better initially, eruptive CNs have significantly worse long-term outcomes.
That's the crucial insight. The need for target lesion revascularization, or repeat procedure, was nearly double, 18.3% in eruptive CNs versus 9.6% in non-eruptive ones.
It's incredible. You get a perfect result on the table,
Yeah.
and the patient comes back a year later blocked up again. What is the mechanism for that late failure?
It's mechanical expulsion. The paradox comes from the reprotrusion of that biologically active eruptive material through the stent struts after you've left. Because the nodule is active, it keeps growing, and the constant mechanical forces at the hinge site literally push that soft material out through the gaps in the stent.
So the stent acts like a cheese grater, and the active plaque, which is softer than the metal, it oozes through the holes.
That's a powerful and accurate way to visualize it. This leads to an in-stent CN. And the risk is highest when the nodule is big, covering more than 180 degrees of the artery. It's almost guaranteed to fail late.
So all of this explains why preparation is everything.
Yeah.
You can't just stamp a stent down. You have to modify the plaque first. Let's walk through the tools, starting with the baseline.
Right. The most common first step is a non-compliant, or NC balloon. Sometimes a specialty balloon like a cutting or scoring balloon.
And what's the goal here? Is it to prepare the lesion, or is it more like a stress test?
It's mostly a stress test, a diagnostic step to determine that deformability that imaging couldn't tell you. The strategy is to use a high-pressure 1.2 sized balloon. And the key indicator, which you need enhanced fluoro to see, is getting full balloon expansion in 2 different views. If the balloon opens fully and symmetrically, you assume it's deformable, and you might be able to go straight to stenting.
And if it doesn't? If you see that dog bone shape, that's your hard stop. That confirms you need something more.
Precisely. But even this has risks. You can get eccentric expansion, or worse, you can dissect the artery at the junction between the calcium and the normal vessel. You're testing the weakest link.
Okay, so if the balloon fails, you move to atherectomy. Let's start with rotational atherectomy, RA. The big challenge here is guide wire bias, right?
It's hugely susceptible to guide wire bias. The burr is centrally mounted. Since the CN is an eccentric bump on one side, the wire can just get pushed to the other side of the vessel, and that pulls the spinning burr away from the actual nodule. So you get minimal effective debulking, especially in a big artery.
So you're spinning this diamond-tipped burr, but you might not even be touching the part that matters.
Exactly. You can try tricks, like using a bigger burr or a stiffer wire, to try and improve contact. But the clinical data is pretty sobering. RA hasn't been shown to reduce the risk of repeat procedures in these patients. It suggests that even when you do it, it's often not solving the core problem.
Okay, what about orbital atherectomy, OA? It's designed to be less prone to that wire bias.
Theoretically, yes, because of its eccentric crown. It wobbles and spins, so it should shave circumferentially. However, the paper shows its effectiveness is critically dependent on one thing: the baseline lumen size where the CN sits. OA works well. It gets a nearly 40% reduction in CN size, but only when the baseline lumen area is already pretty small.
And if the artery is bigger to start with?
The effect is minimal. If the vessel is already moderately sized, the crown just doesn't make enough contact with the nodule to do its job. It needs to be a tight fit.
So with OA, it's all about the real estate. If the vessel's too wide, it's just spinning in space.
Right. It requires meticulous techniques, low passes, maybe high speed, and you really need imaging beforehand to know if the anatomy is even appropriate for the device.
Which brings us to intravascular lithotripsy, or IVL. This is the newer tool. How does it differ from just shaving the calcium?
The mechanism is totally different, and that's its biggest strength here. IVL uses sonic pressure waves to induce calcium fracture. It shatters it, and the key advantage is that it is unbiased. Its effectiveness doesn't depend on the guide wire position like RA or the lumen size like OA. The shock wave just goes to where the calcium is.
That sounds perfect for CNs, especially since we know the tightest spot is often in those flanking sheets next to the nodule.
Absolutely. The unbiased approach is ideal for preparing the entire calcified lesion, not just the bump. And the data from the Disrupt CAD studies shows that IVL is feasible and achieves acceptable outcomes, comparable to lesions without CNs. It suggests that fracturing the calcium is often enough.
But even IVL isn't a silver bullet, right? Especially for that tough one-third of non-eruptive CNs.
That limitation persists. It really highlights how hard some of these lesions are. About a third of non-eruptive CNs remained non-deformable even after IVL treatment. We still don't know for sure if that translates to worse long-term outcomes for those specific lesions, but it proves that even shattering the calcium isn't always enough to make the core fully compliant.
So given that every tool has its own specific weakness, what's next? The paper mentions a dual preparation strategy.
That's the logical next step. The theoretical benefit is clear. You could use atherectomy first to shave off the protrusion to reduce its physical bulk, and that might make the remaining deeper structure more amenable to being fractured by IVL.
So you shave the bump with RA or OA, and then you shatter the foundation with IVL, a 1-2 punch.
Exactly. It would theoretically address both the protrusion and the rigidity. But this is still theoretical. The paper is clear that we need clinical studies to see if the extra complexity and cost actually translate into better long-term outcomes for patients.
Okay, so let's try to summarize this into a practical algorithm for the operator facing some nasty-looking calcium.
Step 1 is non-negotiable. You have to use intravascular imaging OCT or IVUS for any moderate to severe angiographic calcification. You have to know what you're fighting.
So imaging isn't a nice to have, it's mandatory.
It's mandatory. Step 2, assess deformability. Do the stress test with a 1.2.1 high-pressure balloon and use enhanced fluoro to be sure it's fully expanded. Step 3, if it's not fully expanded, you need advanced prep. And step 4, choosing that prep, RA, OA, or IVL is a nuanced decision. It depends on your preference, the lumen size, the potential for wire bias. You have to pick the right tool for the specific anatomical problem.
And the goal before any stent goes in is to achieve full and symmetric balloon expansion.
Yeah.
That's the only real predictor of acute success.
That's the goal.
The big limitation right now is that you only know if it's deformable after you've already tried and failed with a balloon. Are there any emerging technologies that could help us predict this before we even start?
We're looking at a couple of things. Coronary CT angiography, CCTA, might eventually help. By evaluating the nodule's morphology and its density, the Hounsfield units pre-procedurally, we might be able to predict if it's going to be rigid. But even more promising are the hybrid intravascular tools like IVUS or NIRS, or OCT NIRS.
NIRS for near-infrared spectroscopy, which finds lipid.
Exactly. These hybrid tools could evaluate the presence of that residual lipidic plaque associated with the CN.
And why is that so important?
Because the presence of that soft lipid is what makes many of the non-eruptive CNs deformable. If we can identify that soft component in advance, it would tell us there's a high likelihood of successful compression, and maybe we can avoid an aggressive atherectomy procedure altogether. Being able to predict who needs IVL versus who just needs a stent is really the future here.
So last big topic. Given all these unique stent failure mechanisms, the fracture, the reprotrusion, is there a case to be made for avoiding stents altogether and using drug-coated balloons or DCBs?
I mean, that's the ultimate goal, right? To use a technology that eliminates the mechanical failure modes. DCBs are theoretically superior because they circumvent those problems. You don't leave a permanent metal cage at a high motion point, so you eliminate stent fracture. And critically, you eliminate the struts through which that active nodule can reprotrude.
So it sounds like the perfect solution to the reprotrusion problem.
Theoretically, yes. But, and this is a big but, we have to be cautious. This is all based on mechanism. The clinical data just isn't there yet. And you have to weigh that theoretical benefit against the very real risks of DCBs in these lesions. Elastic recoil and the continued regrowth of the CN itself. The source is clear. DCBs can only even be considered if the lesion is adequately modified and prepared first. Without aggressive prep, the risk of immediate recoil would likely wipe out any long-term benefit.
So it's a leave-nothing-behind strategy, but only after you've already won the battle against the calcium itself.
You have to win the battle first, yes. So to conclude our deep dive, calcified nodules remain a highly challenging lesion subset. They require sophisticated imaging and a strictly tailored approach. And despite our advanced tools like IVL, the outcomes are still suboptimal, which really just emphasizes the need for continued refinement of our strategies, especially for these high-risk CKD patients.
And I think the core insight of this deep dive, the real aha moment for you, the learner, is that counterintuitive fact that the lesions that are easiest to acutely, those eruptive CNs, are the very ones that cause the most trouble down the line. That great acute result is betrayed by their biology, by their potential for that mechanical reprotrusion. It teaches us that success isn't just about opening the stent fully, it's about controlling the active biological and mechanical forces that are acting on that plaque long after you've left the room. Thank you for watching The Funnel Effect.